Ok. Bueno, buenas noches. Es un placer para mí y para la Sociedad Argentina de Oncología Oftalmológica. Estamos junto al profesor Pablo Chiaradía para presentar el capítulo 3 de las nuevas fronteras en la oncología oftalmológica, y en esta ocasión van a ser tumores de párpado y vía lagrimal. Vamos a tener un grupo de conferencistas invitados de formadores de opinión internacionales, la doctora Simone Bison de Brasil, el doctor Richard Allen de Estados Unidos, la doctora Rosa Balcells de Chile y el doctor Don Kikawa de Estados Unidos. Los patólogos invitados en esta ocasión, la doctora Lourdes Raca del Departamento de Patología de la UBA y el doctor Abelardo Rodríguez de México. Y los coordinadores van a ser el profesor Daniel Bail, que desafortunadamente no tuvo un problema y no va a estar, tal vez esté para el final del simposium, y la doctora Alejandra Villagra. Pablo, algunas palabras antes de comenzar el simposium.
Es un honor para nosotros el contar con tal prestigioso panel de expertos, y thank you very much for joining us, and it's a great honor for us that stay here again. Really, we admire your work, and that's the reason we have invited you. Thanks a lot for your effort. Thank you very much to come here. Okay, whenever you want, you can start, Alejandra.
Agradezco a todos para estar aquí en el día de la fecha. It is a pleasure for you to have you here. Para comenzar, una profesora y por sobre todo amiga mía, la doctora Simone Bison de la Universidad Federal de São Paulo, nos va a hablar de un tumor de vía lagrimal. Muchas gracias por estar, Simone.
Muchas gracias. Buenas noches a todos. ¿Puede ver, Alejandra?
No, Simone, todavía no se compartió.
Muito.
Tranquila, no pasa nada.
Let's try again. Vamos lá. Share screen. E agora?
Agora sim, perfeito.
Buenas noches a todos. Agradezco a los doctores Alejandra, Daniel, Pablo y David por la invitación. Me siento honrada representando a Brasil nesta noite. Voy a apresentar um caso de tumor del saco lagrimal. El sistema de drenaje lagrimal está composto por todo tipo de células, com predomínio de las células epiteliales. Também temos um rico plexo linfóide e vascular, todo tipo de glândulas e algumas células pigmentárias. Por lo tanto, podemos ter todo tipo de tumores neste sistema, com predomínio de tumores epiteliales, incluyendo el papiloma exofítico ou endofítico, los carcinomas de células escamosas e de transição, los adenocarcinomas, carcinomas de células mixtas, e dentre los não epiteliales, temos a impressão de que ha habido aumento expressivo de los linfomas em las últimas décadas. Representam el 11% de los tumores del saco lagrimal, com predomínio de subtipos MALT e de grandes células B. Já os melanomas malignos representam o 4% de los tumores e todos os demais tipos são extremamente raros. Vou apresentar um caso de uma mulher de 22 anos que se apresentou com uma queixa de massa de crescimento lento durante o último ano, com sangrado recente e secreção purulenta cerca do canto médio do ojo direito. Os antecedentes oftalmológicos e de saúde, todos normais. Em la avaliação oftalmológica de apresentação, se encontrou uma massa fibroelástica que ocupava o canto interno e a presença de uma fístula nesta região. O exame oftalmológico completo, todo normal, e em relação às provas do sistema lagrimal, a prova de desaparição de fluoresceína, 3 cruzes no ojo direito, soft stop e irrigação negativa por canalículo superior e inferior, pressão do saco lagrimal negativa. Os exames físico e de laboratório, todos normais. Não se realizou a dacrocistografia nesta paciente, porque os canalículos estavam obstruídos. Pero em lesões mais pequenas, como nestes 2 casos, pode manifestar-se como uma hendidura na parede do saco lagrimal ou em conducto nasolacrimal. E nesta paciente, a tomografia de órbita mostrou uma formação expansiva na topografia do saco lagrimal direito, com remodelado ósseo, bem delimitada, grandes dimensões, 2,5 por 2,4 centímetros, respeitando os tecidos vecinos, com realce homogêneo tras a injeção do contraste. Aparentemente, a lesão estava septada na região demarcada com a flecha. Revisando o quadro clínico de la dacrocistitis e de los tumores, em las dacrocistitis temos epíforas, signos inflamatórios, lesão quística, consistência blanda, respeita o tendão medial, pode ter reflujo de secreção e fístula. Já os tumores pode apresentar epífora por bloqueio funcional, expansão progressiva, aparência azulada em las lesões pigmentadas, melanomas ou vasculares, consistência firme, não respeita o tendão, pode refluir a sangue, infiltrar-se e causar metástases. Nossa paciente tinha uma lesão sospechosa. A conduta foi, portanto, extirpar toda a lesão e realizar uma biópsia excisional por correlação. Se tumor benigno, continuar com a dacrocisto-rinostomia. Se maligno, continuar com dacrocistectomia. Um outro paciente, para exemplificar que em tumores mais pequenos é mais fácil extirpar todo o saco lagrimal e o conducto nasolacrimal que se aísla do canal ósseo com desperiostizador de Frier delicado, e primeiro, e depois com outro com mais traumático e mais curvo em sua extremidade. Aqui há detalhe do saco lacrimal e do conduto extirpados por completo. Volvamos a nosso caso. Aqui, a delimitação do tumor, a demarcação da linha de incisão, un detalle de la fístula y al término de la cirugía, la sutura de la incisión y de la fístula. Iniciamos el procedimiento drenando el contenido del saco lacrimal a través de la fístula, lo que redujo la tensión de los tejidos en la región, facilitando la disección. Se procedió a la incisión sobre la línea de demarcación y disección del nódulo en el plano submuscular, primero nasalmente e depois temporalmente, tendo muito cuidado de não lesionar as estruturas vecinas. O retrator autostático facilita a exposição de las estruturas mais mediais e assim rodeamos a lesão, preferivelmente com tijeras romas, bastoncillos de algodão e curetas delicadas. O sangrado foi moderado durante toda a cirurgia. A lesão foi grande e bem delimitada. Pouco a pouco, logramos contornar toda a lesão. Hasta que pudiéramos extirpar por completo. Muita paciência. Aqui vemos a fossa lagrimal, os tejidos vecinos sem lesiones e a salida de la sonda de Baumann através do canalículo comum. Grande tumor, 2,6 por 2,1 por 1,3 centímetros, color claro e homogêneo. Parte do tumor foi para correlação em la técnica que se vê aqui. Que revelou focos de atipia. Por lo tanto, finalizamos o procedimento, llenando a cavidade com surgicel, mantendo a salida do canalículo comum e suturando através de planos de tejido. O paciente evolucionou com pouco edema e hematoma, excelente estética e boa oclusão ocular. Em tinção hematoxilina e eosina, vemos que abundam os vasos mais pequenos, que se assemelham a las grietas del tejidos, vasos colapsados por proliferação e áreas mais fibrosas. Aqui, grandes vasos dilatados, de contorno irregular, paredes delgadas e vasos comparados a cuernos de ciervo. Em la imunohistoquímica, a prueba diagnóstica mais específica é CD34, positivo em células endoteliais, evidencia a riquíssima vascularização do tumor. Já a vimentina positivo é compatível com hemangiopericitoma ou tumor fibroso solitário. A primeira descrição dos tumores fibrosos solitários data de 1931, aunque só em 1994 descreveram sua aparição orbitária. As localizações primárias mais típicas ocorrem em la pleura e las meninges, la afectação oftalmológica e especialmente el saco lagrimal é extremamente rara. Pode ocorrer uma transformação maligna e a ressecção em bloco seguir sendo a pedra angular da terapia com intenção curativa. Se deve considerar a radioterapia adjuvante se suspeita de malignidade. Uma vez mais, agradeço a amistade que cresce cada vez mais entre nossas universidades, e em especial a doutora Alejandra, minha amiga, e doutor Daniel, por incluir-me neste evento tão interessante. Muitas graças.
Obrigada, Simone. En el chat no tenemos ninguna pregunta. Entonces, para continuar, va a ser los comentarios del caso, la doctora Lourdes Raca. Ella es patóloga de la Universidad de Buenos Aires y de mayor experiencia y una gran alumna del doctor Zárate. To be continued, the doctora Raca will comment on the case of the doctora Simone.
Bueno, muchísimas gracias por la invitación y bueno, es un placer para mí. La verdad que Simone, muy interesante el caso, y en este caso aleccionador realmente por la poca frecuencia de la localización en saco lagrimal. Es verdad que esta lesión se describió en su inicio como un mesotelioma localizado, por lo tanto se presenta como una lesión fusocelular y el diagnóstico preferencial siempre es con el hemangiopericitoma, por las características vasculares, esos vasos en astas de ciervo. La inmunohistoquímica es categórica para la diferenciación, en este caso el CD34 con esa particularidad, más allá de que tiene que ser positivo, tiene que ser una positividad fuerte y difusa, como claramente lo mostraban las imágenes, de punta a punta, coloreado con la hematoxilina, perdón, con el CD34. Y una característica que lo diferencia del hemangiopericitoma, que es su simulador más franco y por hermandad en cuanto a la apariencia cuando uno lo ve con hematoxilina y eosina, es la bimentina, que también para el hemangiopericitoma es positivo, pero es más débil y en parches. O sea que la característica del tumor fibroso solitario es que siempre da CD34, bimentina, y un nuevo marcador que usamos ahora es el BCL2, que son con las características los tres por igual de ser fuertes y difusos. Y siempre tener presente en estas lesiones, que no era el caso, sino que el caso es benigno por completo, que es como habitualmente se presentan, nosotros debemos buscar como patólogos focos de necrosis, mitosis y de hipercelularidad con alto conteo, como dije, de mitosis. Más de 4 en 10 campos a gran aumento nos hacen pensar en la evolutividad agresiva de la lesión. Si bien son poco frecuentes, suele suceder que cuando recurren lo hacen con mayor agresividad. Y esa mayor agresividad hace que invadan localmente. Esa sería una cuestión como patólogos a tener en cuenta, el conteo mitótico, la necrosis y la hipercelularidad. Pero es un caso muy interesante y muy poco frecuente. Primero que en la economía en general es poco frecuente el tumor fibroso solitario. Y por supuesto en el saco lagrimal es un hallazgo de perlita. Así que muchas gracias por el caso. Muy interesante y muy lindo presentado. Gracias.
Gracias.
Yo, Lourdes, para acotar algo nada más, vi un solo caso que una vez encontró también el doctor Santiago Vivante. No sé si lo ubicás a Santiago,
Sí,
él tiene también un fibroso solitario que también era benigno, ¿sí?
Sí,
no,
sí.
No hay ninguna pregunta en el chat. Entonces, to continue, Dr. Richard Allen. Thank you very much, doctor. He has his practice in Anderson Cancer Center in USA, Texas, USA. He's going to talk to use the spectrum of this in sebaceous carcinoma.
Okay. Thank you so much again for inviting me to come. I really appreciate it.
Thank you for being here today. You can start.
All right. Thanks. Can you see my slides? You can see them?
Perfectly.
Yes.
Okay, we're going to talk a little bit about the spectrum of disease and sebaceous carcinoma. I have no financial disclosures. Traditional teaching in sebaceous carcinoma, common misdiagnosis, delayed diagnosis, recurrent chalasia, chronic unilateral conjunctivitis. What's the consequences of this? Well, results in advanced disease with increased morbidity and mortality. Currently, when we think about the treatment of sebaceous, we want to determine the extent of disease, local, regional, metastatic, complete surgical excision, possible adjuvant therapy if indicated, and then keep these patients on relatively long-term surveillance. When determining the extent of disease, usually we're going to get a biopsy to confirm the disease. Sometimes we need a full thickness eyelid biopsy. We do map biopsies of the conjunctiva, sometimes lymph node evaluation, sometimes a metastatic workup. With regards to complete surgical decision, this can be very difficult with pagetoid spread. I rarely exonerate patients for this problem, but exoneration is still in select cases, especially with orbital extension, wide conjunctival involvement, or in social situations where the patients just won't be able to continue long-term care. When complete surgical resection cannot be performed without exoneration, well, what do we do? Topical mitomycin C, cryotherapy, chemotherapy, possibly targeted agents. There's some reports of success with PD-1 inhibitors. And then we keep these patients on surveillance long-term, clinical, lymph node, repeat map biopsies if needed. So what I'd like to talk about today is really that I've been seeing a lot of sebaceous carcinoma lately. During the pandemic, I've seen about 10 to 15 cases, which is a lot, over a couple of years to me. Usually I'd only see maybe two to three cases a year. And I've really been impressed by the spectrum of disease. And I'm sort of starting to wonder whether it's this wide spectrum of disease that is the reason why there's so much misdiagnosis and delayed diagnosis. And I sort of put this to the pathologist in the sense that, okay, when I look at this disease clinically, it looks very, very different between cases, whereas under the microscope, I think it looks relatively similar, but correct me if I'm wrong. The first case is a 75-year-old gentleman. We're going to start from what I would call easy cases to more difficult cases. So going from, we're basically looking at the entire spectrum of disease, relatively easy, isolated to pretty widespread disease. First one is a 75-year-old male with a right upper lid lesion, biopsy proven to be sebaceous cell carcinoma. So I really have to give it to this patient's ophthalmologist because, basically he flipped his lid and he saw this thing here. So doesn't really look like anything to me. When I look at this patient, it looks like he has a plugged meibomian gland up here and then this lesion here. That doesn't look like anything, but this proved to be a sebaceous carcinoma. And, basically we excised this. He had about a 60% upper lid defect. Margins were negative. Map biopsies were negative, repaired this. And, with negative map biopsies and confident margins, we're just going to keep him under surveillance clinically. He's 18 months out without any evidence of recurrence. So pretty focal case. The second one is a 60-year-old female, worsening irritation of the last 2 years on the left side. She does have amblyopia on the right, of course, and she has a right upper lid biopsy proven sebaceous carcinoma. CT showed no lymph node involvement. So her sebaceous is on the left upper lid here. She is amblyopic on the right side. And we just look at this little area here. And again, not very impressive with regards to what you would think of with regards to sebaceous carcinoma. You could say, well, this has malignant characteristics because there is some lash loss and loss of the architecture of the eyelid, but not terribly characteristic or in the sense that there's any unique characteristic to this that would tell me that obviously this is a sebaceous carcinoma. You may disagree with me. So we did right upper eyelid resection, negative margins, but they're very close medially. She had negative maps. 90% of the upper lid was gone. This was repaired. Map biopsy 7 months later were negative. And however, she does have this postoperative lid retraction from her tarsal grafts. Rather than doing a Cutler beard, I like to do free tarsal grafts with the myocutaneous advancement flap. Tried a scleral lens just because she had irritation, and then we went ahead and recessed this eyelid with creation of lid crease, and she does pretty well afterwards. She's 18 months out also without any evidence of recurrence. Case number 3, 61-year-old man, right upper lid chalazion. So this is sort of the typical story, incised and drained over 2x2 over the last year. And he has this lesion here. Again, fullness to the eyelid. You can understand why this might be thought to be a chalazion. But when we lift this lid, again, maybe, you know, he has this sebaceous looking material here. So a little more characteristic with regards to what we would think of as a sebaceous carcinoma with this yellow lesion. So anyway, he had excision with Map Biopsies, negative margins, negative Map Biopsies, 75% upper lid defect that was repaired with a Cutler beard. Didn't have a good result after his Cutler beard. So every time I do a Cutler beard and I get a bad result, I don't do them for a year because I say, I don't like Cutler beards. But sometimes Cutler beards work great. His did not. So he had a really unstable eyelid, resected that unstable tarsus, or resected that area, and I just replaced it with tarsus from his left upper eyelid and doing well now. So he's 22 months out without recurrence, Map Biopsies 1 year after the initial surgery, all negative, and I'm going to follow him clinically. Case number 4, 76-year-old female, history right upper lid lesion for 2 years, eye indeed, steroid injections, sort of the typical story with these. Underwent a Mohs for a suspected basal cell, but the Mohs doctor said this isn't a basal cell, this is sebaceous. And so they stopped at that time because they did not feel comfortable in proceeding. So here she is. Again, not, you know, definitely some malignant characteristics to this area where she has lost some of the architecture of her eyelid. However, nothing terribly characteristic that's going to tell me that this is a sebaceous carcinoma. Underwent upper lid excision, Map Biopsies. She has some focal intraepithelial cells at the medial edge, and she was treated with 3 cycles of mitomycin. I treat it with 0.02% mitomycin 4 times a day for 2 weeks, and I do 3 cycles of that. So they do 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off, 2 weeks on. Map Biopsies 10 months afterwards are all negative. She has no recurrence after 15 months, and so I'm going to continue to follow her clinically. Another one, 70-year-old male, slowly getting worse and worse with regards to the pathology, right upper eyelid lesion, a little more typical with regards to what we would think of with sebaceous carcinoma. But again, if you look, he really doesn't have any lash loss. This is purely on the conjunctival surface of the eyelid. Resected him. He had extensive disease, but margins were negative, repaired with free tarsal graft, lateral periosteal strip, myocutaneous advancement flap. He got mitomycin again afterwards. Map Biopsies afterwards were negative, but he has a lot of upper lid retraction. So this is my problem when I don't do a Cutler beard, is that I get a little bit of upper lid retraction that I sometimes have to fix with other things. So I'll do a Cutler beard to actually lengthen his upper lid and give him a little better result. 18 months later, Map Biopsies again, all negative, doing well 24 months after his initial surgery. This case is sort of interesting. This is one of my most challenging cases of sebaceous carcinoma because this is a 62-year-old physician who had a left lower eyelid lesion for 1 year. Again, treated as a chalazion. Interestingly, he has this previous right parotid tumor, and there is a study recently that shows that when they look at big data and any associated illnesses with a sebaceous carcinoma, one of them is a parotid tumor. So he had a salivary duct carcinoma. So I've seen about 3 patients that also have parotid tumors who have had sebaceous carcinomas. I tried to send him for genetic analysis and he refused. Actually, he said, it's not going to help your treatment. And I said, well, it could help your children. And he didn't go for it. But anyway, he was convinced that this was an infection. And he walked into my clinic and I said, that's a malignancy until proven otherwise. And I wasn't sure what it was, but I did know that this was malignancy. Again, nothing characteristic about this. If we think about sebaceous carcinoma, really that should be something that originates from maybe the inside of the eye a little bit more. But you know, I looked at this and I said, I think this is malignancy. And, you know, on second thought, when I look at his conjunctiva, it doesn't look completely normal. I biopsied this and I was given a pathological diagnosis of carcinoma in situ. And I asked specifically to the pathologist whether this is a sebaceous carcinoma, and the pathologist our favored squamous cell carcinoma. Again, a question for the pathologist as to how to really determine, I know these can be very tricky, but you know, how to determine sebaceous versus a squamous. Sent for Mohs, and the Mohs doctor actually suspected sebaceous carcinoma. Hughes flap was performed. He was treated with mitomycin C for 3 cycles. High suspicion for recurrence. Map biopsy performed 4 months later. Basically, everything's positive except for a superior bulbar and palpebral conjunctiva. Excised everything, tried to resect everything again, repaired with 3 tarsal graft, mucous membrane graft, and mucous membrane, hard palate even, treated again with mitomycin. And here he is afterwards, and you can see he has a lot of symblepharon here, but vision is good. He has some diplopia, but nothing in primary gaze or reading gaze. Map biopsy performed again, lateral bulbar conjunctiva is positive. I went back to resect. The lateral superior edge is positive. So chasing this thing around and not having a lot of fun doing it. And so the options at this point were either additional mitomycin C, but was worried about doing that with danger to the limbal stem cells, additional excision. You know, to me, I've been sort of losing at this, or additional, or cryo. And so I decided to do wide cryo to everything. And so he tolerated it pretty well. It was pretty rough afterwards, and we'll repeat map biopsies in about 3 to 4 months. And he's 2 years out now after his presentation. So probably my most challenging patient. We have 2 more cases left, just showing sort of my worst cases. 75-year-old female, 4 years of right eye irritation injection. Biopsy previously recommended, but the patient was lost to follow-up. Here she is, red, you know, the chronic unilateral blepharitis look, but we all know that that's not a good thing. And if we look here, you know, I would look at this and I saw her and I said, okay, this is sebaceous cell carcinoma until proven otherwise. But again, nothing absolutely characteristic of sebaceous. I mean, you may argue with me, but again, if you think about all of these cases, none of them look alike. And I think that's part of the problem. So biopsy, the upper eyelid showed sebaceous, upper eyelid bulbar conjunctiva involvement, imaging showed diffuse thickening of the upper lid. I offered her surgical excision with post-op mitomycin C, exoneration, or a second opinion. She went for a second opinion, and I think that they've tried to excise her completely. Last case is 75-year-old female. Entropion noted 7 years ago at that time of biopsy showed sebaceous carcinoma. She refused extensive treatment, tried some homeopathic medications and prayer, and now she complains of nodules on the eyelid. And she comes here and she has these palpable nodules up superiorly as well as laterally. And, you know, you can see the symblepharon formation, and you can sort of get an idea of, you know, what we would think of as sebaceous carcinoma in this patient. Here's her MRI. We have nodules. So she obviously has orbital involvement of her sebaceous carcinoma. And I said, you know, treatment for this. So we went ahead and I went ahead and did a metastatic workup. Whole body PET CT shows no metastatic disease. She adamantly refuses exoneration, refuses chemotherapy or consideration of immunotherapy. And all that she asked was that the palpable disease be removed. And so I actually passed this case to some of my colleagues in the world. And I said, what would you guys do for this? I mean, she's not going to allow me to exonerate her. She only wants the palpable nodules removed, which are what worries her the most. And I said, that's really not standard of care. And I went back and forth, even sent her to my partner here in Houston. And, you know, she is adamantly refusing exoneration. And so basically I said, fine, I'll go ahead and do what she wants. And basically with the understanding that I could increase her risk of metastasis from surgery. And so here she is afterwards, after surgery. So took out a lot of these palpable areas, and she's actually pretty happy. But again, not necessarily, I'm not convinced that I did the right thing for her. And she said, she'll call me if anything grows back. And I said, we need to keep you under surveillance for metastatic disease. And she said, I'm not going to do chemotherapy, even if there is any. And so sort of a tough situation there. I'd be happy to hear what people think. So when we think about a lot of cancers, a lot of them have unique characteristics, which when seen, they immediately tell us what the diagnosis is. And I sort of remember what Ramon Font, a pathologist here in Houston, used to say. He said, when you see, he would show a slide and he said, you need to just know the diagnosis from what you see. It's like seeing your brother at the train station. You instantly know that's my brother or that's my sister at the train station out of this huge mass of people. And I think the problem with sebaceous is that it's everybody. You know, it's not your brother at the train station. There's really this lack of unique characteristics. And I don't think we miss it because it necessarily masquerades always as a chalazion or as chronic blepharitis. It almost masquerades as anything. And when we think about artificial intelligence and how it's going to be used in the future for pathology, radiology, and potentially even some of these clinical lesions on the eyelid and on the skin, I think sebaceous is going to be one that's going to be hard for AI to figure out, because there's really no single characteristic to it that's going to point you that this is sebaceous cell carcinoma. So I think this wide spectrum of disease presentation of sebaceous carcinoma has implications in the sense that obviously, as we know, it's easy to misdiagnose. It's easy to delay the diagnosis, and we always have to keep a high clinical suspicion. Anyway, I just sort of a little story about my recent experience with sebaceous carcinoma and sort of the way that I think about it right now. Happy to answer any questions. Thank you so much.
Thank you very much, doctor. Yes, I have 3 questions. Question to Dr. Donkikawa. What margin for sebaceous cell do you use?
So I go clinical and then I add, so clinically I look to see what I have, and I add about 3 millimeters on top of that. And I don't do frozen, so I do permanent sections. And I'd love to hear from the pathologists as to whether any of them feel comfortable doing frozen section evaluation for sebaceous carcinoma. So I do a delayed closure, I cut it off, I do my maps on my map biopsies on the same day, and then I give it to the pathologist and let them have it for 2 days or so. And I patch the eye, and then I plan to take the patient back to the operating room in 2 to 3 days, either for repair or additional excision.
Do you indict sentinel lymphoma or the biopsy?
Do I do a sentinel lymph node? So, you know, the literature is interesting in that there was a recent review of sort of indications for sentinel lymph node biopsy done by the American Academy of Ophthalmology committee that looks at some of these, I can't remember what the name of the committee is, but it was in ophthalmology probably about a couple of years ago. And I think, you know, right now, if we believe some of the literature, it's if you have a 1 centimeter, or more, so it's T2B tumor, then you send it for sentinel lymph node biopsy. I think it's still relatively controversial. I don't typically do it. I will image patients for lymph node, and sometimes I will keep them under surveillance, their lymph nodes under surveillance if I'm worried about them, either with ultrasound or with CT of the head neck.
Mm-hmm.
To me, I think it's still relatively controversial.
Perfect. The next question is the Dr. Abelardo Rodriguez. He's your patologista comentador. I invito al doctor Abelardo a participar y a preguntar él mismo su pregunta.
Muchas gracias. Primero que nada, agradezco la amable invitación para participar en este webinar. Excelentes casos que acaba de presentar el doctor Allen, que muestra una vez más el amplio espectro que tiene el carcinoma de glándulas sebáceas. Uno es una lesión nodular, borde libre, color amarillento, ulcerada. Esa es una historia no muy difícil para todos, pero el espectro de lo que él acaba de mostrar es una situación no poco frecuente para la práctica de la, digamos, oculoplástica y la patología oftálmica. Varias consideraciones desde el punto de vista de anatomía patológica. Cuando se recibe una pieza quirúrgica del cirujano, antes de realizar todos los estudios especiales, creo que lo más importante es hacer un muestreo amplio de la lesión. Hacer cortes seriados, 2-3 milímetros, meter los bordes y poder saber si la lesión fue resecada completa o no. Segundo, ver el grado de diferenciación. Un carcinoma bien diferenciado no tiene mucho problema, pero un carcinoma pobremente diferenciado es una neoplasia que puede confundirnos al patólogo con otras lesiones. ¿Por qué? Porque puede tener diferenciación escamosa. ¿Por qué? Porque puede tener diferenciación basaloide. ¿Por qué? Porque puede tener un aspecto sarcomatoide o puede tener un patrón neuroendocrino. Y estamos clasificando la neoplasia como un tumor de una estirpe diferente. Hacer un amplio muestreo. Y cuando los cirujanos decidan hacer un mapeo y tomar biopsias de conjuntiva vulvar, conjuntiva tarsal, córnea, etcétera, pedirles que nos envíen las biopsias en recipientes separados muy bien rotulados para que nosotros podamos decirles cada sitio si se encuentra libre o no de tumor. Y en ese mapeo que se hace sobre todo cuando se sospecha de una diseminación intraepitelial, la mayor parte de las veces de tipo palletoide, nos orienta mucho al patólogo a tener en cuenta que esa es la manera como va a diseminarse el tumor en los epitelios, principalmente conjuntiva tarsal, pero puede llegar hasta la conjuntiva vulvar e incluso limbo y córnea. Desde el punto de vista de inmunohistoquímica, la inmunohistoquímica quizás la dejamos para carcinomas pobremente diferenciados, por un lado. Hay que tener mucho cuidado porque los carcinomas de glándulas sebáceas pueden tener una expresión similar a otros carcinomas. Probablemente podemos empezar con una programación de una pancitoqueratina, incluyendo la citoqueratina 7, y algunos otros marcadores que pueden tener una expresión muy variable son marcadores del tipo de la adipofilina, el antígeno de membrana epitelial, receptores de andrógenos, otra citoqueratina que es el VER-EP4, marcadores muy específicos como P40 e incluso ver cómo se ve la expresión de P63. De tal manera que esto es una secuencia de pasos que empezamos de lo general a lo particular y hay que hacerlo siempre de esa manera, porque cuando empiezo a abreviar pasos, un mal muestreo, empiezo a programar la inmunohistoquímica antes de la morfología, me voy a meter en problemas de interpretación. De tal manera que, pues eso es lo que les quiero compartir desde el punto de vista histopatológico y una vez más felicito al doctor Allen por su brillante exposición. Muchas gracias.
Doctora Abelardo, ¿le podría hacer la pregunta a usted de que me planteó de utilización de crioterapia?
Okay, Dr. Allen, my question is, do you recommend frozen sections for sebaceous cell carcinoma or do you prefer definitive sections?
I prefer the definitive. I think it's really the question for the pathologist. I think, I haven't found a lot of pathologists that feel comfortable with frozen section. And I personally, there's some Mohs surgeons that believe that they can do Mohs for these procedures, and I just haven't been convinced. I know that there may be some new stains that can be used for frozen section evaluation, but I do not typically use frozen. I do definitive permanent and do a delayed closure so that the pathologist can look at it over 1 to 2 days.
Por último, cuando llegamos a realizar una valoración en nuestra experiencia, cortes por congelación, como dice el doctor Allen, hacemos un corte adicional de tejido fresco para poder hacer tinciones para lípidos. Y muchas veces una tinción de rojo oleoso, un sudán negro, nos puede ayudar a tratar de ver si el contenido de las células es lipídico o es de otra naturaleza, como pasa con el carcinoma vasocelular o incluso el carcinoma de células escamosas. Muchas gracias.
Gracias, doctor Abelardo. Dos questions, Dr. Allen. One, Doctora Rosa Maria Balces. Your question is, you always use the map biopsies of conjunctiva?
I do. I don't know, again, this is somewhat controversial. I do global map biopsies. And so what I mean by that is that I do take it 360 degrees around the conjunctiva. Some people disagree with that and say, no, you don't need to do that. If it's on the upper lid, you don't need to go all the way to the inferior bulbar or palpebral conjunctiva, especially if it's not clinically needed. But I do map biopsies on all of my patients with sebaceous. I do it at the same time that I do the first excision, just to make sure that there isn't any pagetoid spread that may need to be treated.
Other question, the Dr. Pablo Chiaradia.
Yes,
For
please.
the general okay, doctor.
Okay, thanks. Your presentation, Professor Allen, was amazing. Congratulations. Thank you very much. And because I came from the cornea world and just asking you, the methomycin, it's a little hard for our patients. And is there any indication for use in interferon?
I don't think that there's any evidence at this point that interferon has been found to be successful in the treatment of sebaceous carcinoma. I don't know of any studies that have shown that.
Okay, thank you so much. And usually in some biopsies, you use usually amniotic membrane to set.
If there's a lot of bulbar conjunctival involvement, then yes, we'll put amniotic membrane on top of that. Yes.
Okay, thanks so much. Thanks.
Thank you.
Thank you very much, doctor. For continue, la doctora Rosa Balces, del Hospital Salvador del Centro de la Visión de Chile, y también otra gran amiga. Ella nos va a hablar de un tumor del saco lagrimal. Muchas gracias, Rosita, por estar aquí.
Ahí. ¿Se escucha o no, Ale?
Sí, se escucha perfecto.
Ok,
¿Cómo
bueno.
estás?
Muy bien, muchas gracias por la invitación. Un orgullo estar aquí compartiendo con estos grandes sabios de la oftalmología y de la patología en casos tan complejos, ¿cierto? Que son siempre los tumores. Antes de partir, que tengo I have a small question for Richard Allen. Do you say that you always do the map biopsy? And I have also a question for the pathologist, because normally what we do, which is not right, I don't know, is that we wait for the pathologist. If the pathologist informed that there is a pagetoid kind of tumor, we go back to do the map biopsy, which I'm really scared of, because we have had a couple of cases, that white eye, and you have positive, like small biopsies very far away from the tumor, and then you have to what are you going to do? You said that you use mitomycin, and does it work?
So I think it works, but I had a discussion of this with actually Carol Shields, and she's a big proponent of cryo. She likes cryo a lot for sebaceous. And so I may start using cryo a little bit more. But I mean, if you look at the literature, yeah, mitomycin is, people describe success with it. And I think that it gives me a little bit, I don't think that if you have widespread disease, no, I don't think that it's probably the way to go. But if you have like a small area of pagetoid spread and it's close to your margin, then yeah, I use mitomycin. I use it pretty liberally. I use it a lot, and I think a lot of it is for my peace of mind. I'm treating myself rather than the patient, in the sense that I just want to do everything I can to try to prevent any recurrence of this tumor.
Thank you. And doctora Abelardo, para la pregunta para usted, en el fondo nosotros como cirujanos podemos esperar el informe de ustedes diciendo que, que tiene una diseminación palletoide y por lo tanto ahí ir a hacer las biopsias mapeadas, o debería ser al revés?
Doctora, yo creo que como algunos de los casos que mostró el doctor Allen, en donde no se ve propiamente una masa muy bien definida, sino, por ejemplo, esa conjuntiva muy hiperémica, ligeramente sobrelevada, un poco tumefacta. Yo creo que son esos casos donde uno sí tiene que indicar que se haga un mapeo desde el principio. Y la otra recomendación me parece que es buena, sobre todo cuando trabajan de la mano con un patólogo general que no ve tantos carcinomas de glándulas sebáceas, es que le manifiesten ustedes la sospecha de un probable carcinoma de glándulas sebáceas, porque me ha tocado ver en una segunda opinión biopsias de conjuntiva tarsal vulvar que se han biopsiado sin notificarle al patólogo y estar diagnosticadas como una neoplasia intraepitelial conjuntival, como una lesión in situ de la conjuntiva y no como diseminación intraepitelial de un carcinoma sebáceo, que eso es la parte más delicada. Y se pierde un tiempo muy valioso, de tal manera que vale la pena en su solicitud indicar sospecha de carcinoma sebáceo para que el patólogo general esté alerta y busque intencionalmente los cambios palletoides de esta diseminación.
Perfecto, muchas gracias. Bueno, yo les voy a presentar un caso bastante simple, pero de un tumor de saco lagrimal que conversábamos con Alejandra. Agradezco nuevamente la invitación a Ale, al doctor Bail, sobre estos tumores que son raros, ¿cierto? Los tumores de la vía lagrimal excretora son bastante infrecuentes y no nos toca toparnos con tantos tumores durante nuestra práctica diaria. Entonces, este es el caso de un paciente de 60 años masculino, cuyo único antecedente es que tiene una diabetes, toma algunos medicamentos para ello, y su motivo de consulta es que tiene una historia de epífora o lagrimeo de 2 años de evolución asociada a un pequeño aumento de volumen en el área del saco lagrimal del ojo derecho, que es indolora. So, it's a 60-year-old male, 2 years of tearing and a small bump in his lacrimal sac area in the right eye. En el examen clínico, una visión normal, y les voy a decir solamente lo destacado para no perder mucho tiempo. Tiene un aumento de volumen visible en el área del saco lagrimal derecho, que es de consistencia gomosa. Y en la biomicroscopía destaca en el ojo derecho un tear lake que está aumentado, el punto lagrimal está presente y se ve perforado, o sea, permeable. Tiene una facoesclerosis y el resto del examen es normal. En el ojo izquierdo la vía lagrimal también se ve normal. No se le hizo irrigación porque claramente hay una obstrucción que se nota visualmente. Y se plantean 2 hipótesis diagnósticas. Primero, la posibilidad de que el paciente tenga un dacriocele, mucocele del saco lagrimal derecho. Y la segunda es que sea un tumor de saco lagrimal. Entonces, el plan que se hace es pedir unos exámenes preoperatorios pensando que el paciente va a necesitar una cirugía y una tomografía a ver si nos muestra o nos ayuda a caracterizar mejor este aumento de volumen. Y se plantea eventualmente una dacriocistorirrinostomía con drenaje o la resección del tumor con biopsia de acuerdo a lo que vayamos encontrando en los exámenes. Entonces, en el escáner, aquí podemos ver una imagen, en la ventana ósea se ve esta imagen de aumento de volumen en el saco lagrimal derecho importante, ¿ya? Y que en las imágenes de tejidos blandos se ve cómo se refuerza el tumor con el contraste. Y esto es una manera, aquí tenemos un pequeño video a ver si corre, del escáner de la ventana de tejidos blandos, donde se ve cómo va a reforzar este tumor, y esto es lo que nos ayuda a diferenciar cuando el tumor refuerza un poco con el contraste, es decir, se ve más blanco. Uno tiene que tender a pensar que hay algo de vascularización y por lo tanto descarta un poco la idea de que esto pueda ser un dacriocele o un mucocele y se orienta mucho más a que pueda ser un tumor sólido de alguna naturaleza. Entonces ya entramos pensando que esto podía ser un tumor sólido y se hace una cirugía donde se hace una resección donde se reseca completo el saco lagrimal con el tumor. La verdad es que la resección fue relativamente sencilla, el tumor era grande, pero se disecaba perfectamente el saco sin grandes problemas y como muy bien lo describió Simone en su presentación, este tumor llena como que fuera un molde el conducto nasolacrimal, pero sale completo sin ninguna adherencia desde el conducto nasolacrimal. Entonces, el tumor se manda a estudio histopatológico. En ese minuto se decidió obviamente resecar todo el tumor. Dejamos una intubación con sonda de silicona de la vía lagrimal hacia el conducto nasolacrimal y no se realizó la dacrocistorrinostomía, que se había planteado como una posibilidad de acuerdo a las características de este aumento de volumen. Y aquí se ve nuestras primeras láminas del tumor. Esto es un aumento de 2X hematoxilina eosina, donde se alcanza a ver en la flecha azul la pared del saco lagrimal y arriba, donde está la flecha roja, ¿cierto? Una gran masa tumoral papilar que tiene brotes exofíticos de epitelio escamoso. Aquí con un poquito mayor aumento, nuevamente en la flecha azul se ve el epitelio del saco lagrimal, que es un epitelio cilíndrico mucosecretor con algunas células caliciformes, y después esta gran masa papilar, ¿cierto?, a superior que nace desde la pared del saco. Ahí se ve desde el nacimiento desde la pared del saco. Y aquí con mayor aumento podemos ver como la transición entre la pared del saco lagrimal con epitelio mucosecretor y la anoplasia, que tiene estos brotes papilares exofíticos con displasia celular. Entonces, y aquí otra imagen más con algún detalle. Entonces, el diagnóstico histopatológico de este paciente fue un papiloma escamoso con displasia intraepitelial de bajo y alto grado. Entonces, a continuación, el paciente se hizo una interconsulta otorrino y cirugía oncólogo de cabeza y cuello. Se realizaron resonancias magnéticas de órbita y senos paranasales que no mostraron restos de tumor, y se ha hecho seguimiento con resonancias magnéticas hasta hace 2 años, que luego de la pandemia el paciente perdió los controles. Sin embargo, el paciente está asintomático actualmente, no presenta molestias y tampoco tiene epífora. Entonces, los tumores del saco lagrimal, como bien describió, comentó Simone, son infrecuentes. Y aquí esto es un review interesante que se publicó en el Orbit en el año 2010 de un grupo alemán, en donde tomaron varios papers con distintas descripciones de tumores de saco lagrimal desde el año 52. Como no son tan frecuentes, uno no encuentra series con demasiados números. Sin embargo, una cosa que me llamó mucho la atención de esta tabla es que, si bien los tumores epiteliales son más frecuentes que el resto de los tumores, o eran, porque como bien dice Simone, se cree que han ido aumentando, ¿cierto?, los de origen linfoide. Lo que más me llamó la atención es que dentro de los epiteliales que son más frecuentes, los malignos son más frecuentes que los benignos. Entonces eso me hizo pensar a mí que cuando uno se enfrenta a un paciente que tiene un aumento de volumen del saco lagrimal, no solamente tiene que pensar que está frente a un tumor raro, sino que la probabilidad de que este tumor sea maligno la sospecha tiene que ser mayor aún. Entonces, esta es una foto, para terminar, de uno de los últimos congresos que tuvimos presenciales ahí en Rosario, en el Paraná, con los argentinos, disfrutando con Daniel de una navegación preciosa por el río. Súper.
Muchas gracias, Rosita, como siempre, hermosa presentación. Muy raro el caso, realmente nunca había escuchado este tipo de tumor y más en el saco lagrimal. Y sí, cuando uno ve algo en el saco lagrimal y que aumentó de tamaño, y siempre sospechar primeramente que es maligno, ¿sí? Nunca vamos a pensar, siempre vamos a ser mal pensados. Bueno, para continuar, la doctora Lourdes Raca va a hacer los comentarios sobre el caso de la doctora Balcés.
Bueno, Rosa, la verdad que hermoso el caso, la verdad muy interesante. Es cierto que las lesiones benignas, cuando se presentan como masa, uno siempre, generalmente palpables y endurecidas, uno piensa generalmente que son lesiones malignas. En este caso, el papiloma, que surge, como se ve claramente, a partir del epitelio de revestimiento del saco, en sectores, si bien, como bien dijiste en la descripción, es exofítico, en sectores uno puede apreciar que tiene un crecimiento hacia el interior del estroma, es un patrón endofítico. Estos tipos generalmente, o la combinación de ambos, exo y endofíticos, son más frecuentes que los puros, ya sean exo o endo cada uno por su lado. Lo que hay que tener siempre presente es que cuando uno encuentra el componente endofítico, que este componente no tenga alto contenido mitótico, y fijarse bien en la presencia de la posibilidad de permeación vascular, ya sea linfática o sanguínea, porque nos estaría hablando de la presencia de una posible transformación maligna de estas lesiones. Este tipo de lesiones se caracterizan por tener generalmente un tipo celular que puede ser, como lo es en este caso, de tipo escamoso. Otras veces puede ser que presenten como en este sector, más de tipo transicional, que es lo que se homologa al tipo de epitelio de la vejiga, por eso así se llama, y sino que sean, en la mayoría de los casos, de tipo mixto, como bien está representado en el caso que presentaste, Rosa, que es en sectores de tipo transicional y en sectores de tipo epidermoide. Siempre cuando uno tiene este tipo de lesiones, lo que tiene que valorar no solamente es, por supuesto, el crecimiento, si es endo o exofítico, y después las características de la presencia o no de displasia, el grado de displasia que tenga. Lo mismo que hacemos con la conjuntiva cuando encontramos una lesión papilar, se hacen este tipo de lesiones, catalogar el grado de displasia, y siempre la secuencia tener en mente que estas lesiones, como suceden con el carcinoma, porque el carcinoma epidermoide vendría a ser el tumor maligno más frecuente de saco lagrimal, entonces lo temible sería que esta lesión en algún sector tome el estroma y realmente haga una franca invasión del mismo, y seguir, por supuesto, que es lo que quiere hacer todo carcinoma invasor, buscar la posibilidad de permear una luz vascular para cumplir su premisa como tal, es decir, poder dar metástasis a distancia, que en este tipo de lesiones, si fueran en carcinoma, hay que controlar siempre la metástasis o sea, el regional de ganglios linfáticos y a distancia. Por eso siempre es importante seguir minuciosamente todo el contorno de la lesión para descartar la permeación incipiente del estroma con intento de, obviamente, permeación vascular sanguínea o linfática. Muy interesante el caso, y es verdad, son poco frecuentes, y cuando aparecen, obviamente que alertan, y son casos que como anatomopatólogos llevan siempre a la segunda opinión también. No son fáciles de resolver, precisamente porque son muy hipercelulares, hay papilas muy fusionadas, y lo que hay que descartar, como dije, es la posibilidad de una transformación maligna si sea focal dentro de toda la región. Hermoso el caso, y gracias por compartirlo, muy interesante.
Yo tengo una pregunta para el resto de los doctores. ¿Le puedo o no?
Sí, ¿cómo no?
Sí, la verdad es que la gran duda que queda aquí es cómo hacer el seguimiento clínico de este paciente. En el fondo, hasta qué punto un tumor que tiene un riesgo de malignizarse, uno queda tranquilo y dice, ¿sabes qué? Sacamos el tumor entero, queda algo. Y claro, hacer seguimiento con resonancia magnética es lo único que ayuda, pero la zona donde está es difícil. Entonces yo ahí tenía mis cuestionamientos si vale la pena hacer un tratamiento, de repente pensaba incluso mitomicina o algo más para tratar de garantizar que no tenga una recidiva este paciente o una malignización si es que quedó algo de tumor adentro, ¿no?
Rosita, aprovechando que está el doctor CAO y el doctor Allen, haz tu pregunta en inglés, así ellos pueden contestar de forma directa.
Okay, so I have a question for you from this case. Like, this is a benign tumor, but with a high risk of turning malignancy. So after I remove the tumor and we follow up this patient just with MRIs, and then how can we do a follow-up and make sure this is not going to get, he's not going to get an invasive tumor afterwards? Because I'm not confident that MRI is going to be enough if you don't have like a big, area of infiltrate or invasive tumor to be able to see it. And if I'm confident I remove the whole sac, I don't know if that is enough to just be confident that there is no leftover of tumor in there. So what would you think will be a proper follow-up for this patient, or treatment? Maybe use the mitomycin will be a good reason to use it here. I don't know. What do you think?
Yeah, I mean, from my standpoint, we treat these pretty aggressively. Usually for any of the lacrimal sac tumors, truly I get my head and neck colleagues involved, and they usually do a medial maxillectomy with it. And then, radiation, we would usually follow it up with radiation. And it's, to be quite truthful, it's not uncommon for you know, a free flap to be placed after the resection that can tolerate radiation. So I think we're on the overly aggressive side, you know, in the sense that I think there's probably a happy medium between, you know, what you're doing and then being really, really aggressive, because, you know, a lot of times you put these patients through these big surgeries and, you know, you look at the pathology of the lesion and it's really not that worrisome. But there is always this possibility of transformation down the line. And I think a discussion with the radiation oncologist would be reasonable. And then surveillance as you're doing. I don't think I'd do anything more.
Yeah, I think I maybe would take a little bit more conservative approach. And mi español no es muy bueno, pero entiendo.
No problem, doctor. And English.
As I understand it, this is an inverted papilloma. And
it's just it's not an inverted papilloma. It's a papilloma with a high grade, but not malignancy yet. I don't know how to translate it in English. Maybe the pathologists can help us. Maybe they know better how to put it in English.
And it was excised externally, right? You made an external.
Yes, just so like a DCR, like a big incision in there, and remove the whole sac and all the tumor that went in through the NLDO, and it came out really easily because it was just like a mole going inside in the nasal lacrimal duct.
Right. I think Rich is right. I would involve our ENT colleagues. I think probably periodic examination beneath the inferior meatus, where you're actually looking at the nasolacrimal duct opening, is good, because it's either going to grow kind of distally or proximally. So you can track the growth, you know, if you directly visualize underneath the inferior meatus or the inferior turbinate and look at it that way. I think without malignancy, I would be hesitant to proceed with a medial maxillectomy, but that's just my, you know, I know Rich probably sees these big tumors, and maybe his service there is a little bit more aggressive, but I think we probably would manage it a little bit more conservatively and observe for a while.
Yeah, that's what we're doing. Like ENT and head and neck oncologists are following up with me, but you're always concerned because we have been very conservative. You're just following up. So we are always concerned that something, you know, grows in there and we are not able to look at it.
Right.
It's very bad location for a tumor, I guess. I don't know.
Bye. Thank you very much. To continue, the Dr. Don Kikawa. He has practice in the University San Diego Shirley Age Institute, California, Estados Unidos, USA. Thank you for being here today, young start, doctor.
Thank you very much, Dr. Balagra and Dr. Weil, for inviting me. And it's such an honor to be here and to follow such distinguished speakers. And I really like the format of interacting with pathologists. And I think we learn a lot from each other. So congratulations on such a innovative format. So I'm going to spend most of my time discussing one case. This was kind of a new case for me in that we saw 3 carcinomas very close to each other in one eyelid. So these are my disclosures. As we all know, there are general risk factors for the development of skin cancer. Certainly, ionizing radiation is probably the highest risk. Certainly, it's worse around the equator and also worse in areas where the ozone layer is deficient. Age is probably the second most impactful factor, followed by immune suppression, genetic predisposition, lightly pigmented skin, and heavy metal exposure such as arsenic, cadmium, chromium, and lead. The incidence of skin cancer is on the rise. The population, as we all know, is aging. However, the mortality appears to be stable or slightly decreasing. And this, I believe, is from the large benefit of better detection, earlier treatment, and even therapy in advanced cases. However, the mainstay of treatment continues to be excision and reconstruction. Our case features a 90-year-old woman who presented with a rapidly enlarging mass in her right lower eyelid for 2 weeks. On examination, she had a 1.5 centimeter non-tender erythematous nodule. Another lesion was located just medially as an eroded macule in an area of photodamaged skin. She had multiple actinic keratoses on her face. Also of note was 10 years prior, she had a basal cell carcinoma, which was completely excised with Mohs micrographic surgery and reconstructed without incident. Her medical history is otherwise unremarkable. So she's a relatively healthy 9-year-old woman without any predisposing medical risk factors. She was not immunosuppressed. She was not on any chronic medications, denied heavy metal exposure. Obviously, she grew up in California, which is a high sun exposed area. So this is how she presented. And as you can see, this is her right lower eyelid. It's causing mechanical ectropion. You can see the multiple actinic changes that we see on her face. The first thing you'll note is that there is a scar just below the larger mass. That's a horizontal scar. This was the site of the previous basal cell carcinoma. You'll also note medially here, there's this ulcerated lesion in kind of this background of actinic damage. And then there's the third larger lesion here. So we have what appears to be 3 different cell types of lesions in a very close area of proximity. So we performed a full thickness wide excision with 5 millimeter margins. Like Dr. Allen, we use a very slow Mohs technique where we send margins for permanent section. We await for the margins to come back clear before we proceed with any reconstruction. Once we got the word from our pathologist, we performed reconstruction with a tarsoconjunctival pedicle-based flap from the upper eyelid, adjacent tissue flaps, and also skin grafts to reconstruct the eyelid. So I'm going to let our pathologist comment on the details of Merkel cell, but the larger lesion ended up being a Merkel cell carcinoma. Here is the immunohistochemical stains that were positive and negative. We had epithelial membrane antigen, cytokeratin 20, chromogranin, synaptophysin, and neuron-specific enolase were positive, and we had pancytokeratin and P63 negative. Apparently CK20 with the cytoplasmic perinuclear dot staining as seen here in the bottom inset C is fairly specific for Merkel cell carcinoma. This was the adjacent squamous cell carcinoma, very typical findings, and we don't have the pathology on the basal cell, which was done 10 years prior. So lymph node staging was offered as well as radiation. And in view of the patient's advancing age, being in her 90s, she declined further treatment, as well as after discussing with her family, they really did not want any further treatment done. Follow-up at 15 months showed her to be tumor-free. So the eyelid skin cancer, varies in incidence based on population. I'm sure in the US, we have a much different incidence of certain skin cancers as opposed to Asia or Africa or possibly even South America. In order of decreasing incidence, we see basal cell carcinoma as the most common, followed by squamous cell, followed by melanoma. Dr. Allen sees sebaceous cell on the rise. Perhaps sebaceous cell might be more prevalent in certain populations. And then as number 5, we have Merkel cell. So Merkel cell carcinoma is a highly malignant neuroendocrine tumor arising from the sensory Merkel cell, which is associated with proprioception. It has a predilection for the head and neck. It has associated risk factors. About 80% of cases are positive for the polyomavirus. And the use of TNF-alpha inhibitors such as adalimumab and golimumab have been associated with a positive risk for Merkel cell. There's a 97% 5-year survival rate in pathologically negative lymph node patients, and that drops to 52% 5-year survival with positive lymph nodes. There are some promising results from monoclonal antibodies as well as small molecules which inhibit the PD-1 and PD-L1 pathway. So let's just maybe take a step back and see what the chances are of 3 different cancers developing in one eyelid. So this is the statistics for basal cell and squamous cell were taken from a study in BJAO in 2002. So about 4.53 people out of 100,000 per year will get a basal cell on their lid. And about 2.42 will get squamous cell on their lid. And if we look at Merkel cell, that drops to about 0.23 per 100,000 per year. So this is just looking at eyelid only. This is not looking at face or other areas of the body. So for the risk of independent events to occur, we multiply the risk. And because this patient was 90 years old, we would multiply by 90 because this is the annual risk. So the first calculation we have is 4.53 times 90, divide by 100,000, times 2.42, which is the risk of squamous cell, times 90, divided by 100,000. And the lifetime risk of Merkel cell for this patient was 0.23 times 90 divided by 100,000. So adding all 3 of these up, we end up with 0.0000183%, which to me seems fairly low. Probably at the time the study was done, compared to now, we probably see a little bit higher incidence of basal cell and squamous cells. So probably we're a little bit higher than this percent that I calculated. So in conclusion, this patient had 3 carcinomas in very close proximity in one eyelid: basal cell, squamous cell, and Merkel cell. Advanced age, light-colored skin, ultraviolet exposure are the only risk factors for this patient. There was no syndromic association or any underlying immunosuppression or any risk factors. And the lifetime risk of developing all 3 of these cancers in one eyelid is as listed. So I will stop here, and I look forward to hearing what our pathologist has to say. And thank you once again for inviting me to speak.
Thank you very much, doctor. The probabilities is way easier to win the lottery. Well, I don't know the question. Te continúo de doctor Abelardo González para comentarles.
Okay, amazing case, congratulations. I have never seen a case like this before. Okay, sorry, my comment is in Spanish, but la presencia de más de un tumor en una misma localización, lo muestra el doctor perfectamente en su plática, es extremadamente poco frecuente. Y en la experiencia personal sí me ha tocado ver la presencia de 2 lesiones, maligna y benigna, la mayor parte de ellas, en una misma localización como el párpado, como es la presencia de un carcinoma vasocelular y alguna otra lesión benigna del tipo del nevo o del tipo de un hidrocistoma apócrino, que no es una situación tan extraordinaria, quizás porque el carcinoma vasocelular se desarrolló posteriormente en donde había un nevo preexistente o se complicó un poco la dilatación de una lesión quística benigna y eso da origen a que haya 2 lesiones. Cuando esto sucede, me parece que la mejor manera de llamarlo sería un tumor o una lesión de colisión. Coinciden o convergen en un mismo sitio o localización y se originan que son capaces de resecarse. Yo revisando un poquito la literatura, encontré una publicación de un estudio en lesiones cutáneas, en donde se hace un estudio retrospectivo en 40,000 biopsias cutáneas y se encuentran solamente 69 ejemplos que coincidan con estas lesiones de colisión. Esto con las combinaciones que ya mencionamos, carcinoma vasocelular, con alguna otra lesión, incluyendo lesiones de anexos. Pero mi sorpresa, y es algo que yo quisiera preguntarle al doctor, qué experiencia tiene, es que encontré una entidad que no tiene demasiado tiempo tampoco en la literatura, que lo llaman mosque in a nest. Y el mosque in a nest es una terminología que se usa para llamar neoplasias de piel múltiples, multiple skin neoplasm at one site, y eso es lo que lleva el acrónimo de mosque in a nest. Y el mosque in a nest mencionan que es la combinación de carcinoma vasocelular tanto con tumores benignos, la lista es muy grande, lesiones de anexos, lesiones del folículo piloso, tumores sebáceos, así como carcinoma vasocelular con algunos otros tumores malignos que pueden ir desde lesiones limítrofes como las queratosis actínicas, angiosarcomas, fibrojantomas atípicos, hasta otras estirpes. Por ahí hay una descripción de una leucemia linfocítica crónica, por supuesto, como el que acaba de mostrar el interesantísimo, un tumor, un carcinoma de células de Merkel, hasta neoplasias de otras estirpes como serían osteosarcomas, muy probablemente de tipo metastásico. De tal manera que es una entidad que no vamos a ver muy frecuentemente, no sé si nos toquen más de una o más de una entidad, pero me gustaría saber y preguntarle al doctor si él tiene alguna experiencia con esta terminología del mosque in a nest. Muchas gracias.
Doctor Kikawa, the
Yes.
doctor Abelardo, you question is you then experience in the monks in Alex, Abelardo, the monks.
I read an entity and the name is mosque in a nest when there are more than one tumor in the same location. Could be a good, nomenclature for this type of tumor, or we need to use better collision tumor. What is your experience in this, doctor?
Well, I think it's very common to see, we see commonly patients in their 90s, even in their hundreds, and I'm sure Richard and Rosa see the same population, but it's very common to see two types of skin cancer. I think we see basal and squamous very commonly. Occasionally you see someone who's had a melanoma also. But I think, the rarity of this, and I think lightning just struck 3 times in this particular patient. I don't think there was anything in particular that she had that was any different, but I don't know. I'm interested to hear what maybe Richard and Rosa think.
Yeah, I think it's interesting. I mean, I think I was just writing a comment to you about this. Basically, I think it would be interesting to look at all of our skin cancers and how many times people have 2 together and sort of see which ones go together. I mean, obviously, when you have 1 basal cell or you have 2 basal cells, I think it's a pretty good chance that you're going to crop up another basal cell if you've gotten 1. But when a basal cell or a squamous cell or, some of these other skin cancers occurred together, it would really be interesting to look at the population of patients and see if there's anything in common between them or if it's just bad luck. I think you'll probably see a lot of immunosuppression. You'll probably see, genetic factors with regards to, ethnicity and that kind of thing. I had an interesting patient a while back, and he was a cancer patient, so really, really immunosuppressed, who had a melanoma, squamous cell carcinoma, basal cell carcinoma, and it's just, for him though, it was obviously, the cause of that was pretty obviously just because of his immunosuppression. But, it would be interesting to, I think, put a study together where we looked at, where everybody sort of got their patients that had 2 or more different types of skin cancers and seeing, okay, what is it about these patients that sort of makes them different? Or is it just bad luck and just happens for no good reason?
Right.
Okay.
Perdón, doctora.
Dr. Kikawa, a question. Do you think that in this case, the treatment with the immunotherapy
I think we lost her.
Yeah, looks like Alejandra's frozen.
Yeah, she's frozen.
Oh, there you are.
The amazing thing about your case, Don, is that the proximity of the 3 different tumors is amazing. It's not only to have the 3 of them, because 90 years old, white, some damage, you can have the basal cell and the squamous cells like everywhere, you know, but having the Merkel and the other 2 so close together, that's amazing. And that's what Dr. Abelardo was saying about the multiple skin tumors in one side. That's something that is described apparently. I haven't seen that before.
Yeah,
Alejandro, we lost you and then you're back. We lost you mid-sentence.
You had a question, Alejandra.
I'm sorry, my internet bad. Do you think that in the case the treatment with the immunotherapy difference, it is important or no? Como bismogidib or other.
Right. I think we're seeing probably focused immune therapy that might be more effective. I think currently surgery is better, you know, for patients that can undergo surgery or perhaps an advanced disease. I think we have options for monoclonal therapy or small molecules. But I think right now, you know, it's cost prohibitive in many patients. And then I believe still here the standard of care is excision and reconstruction.
Mm-hmm. Okay. ¿Alguna pregunta? ¿Alguien más? Doctora Abelardo, doctora Lourdes.
Sí. Me gustaría comentar nada más
sí.
Desde el punto de vista histopatológico, sobre todo en la asociación más frecuente, como mencionan los doctores, de carcinoma vasocelular con carcinoma escamoso, antes de llamar como una lesión de colisión, quizás hay que pensar que puede ser una misma neoplasia con diferenciación en algunas áreas de tipo escamosa, y lo mismo con el carcinoma de glándulas sebáceas, porque el carcinoma de glándulas sebáceas puede tener zonas de diferenciación escamosa y no pensar que son 2 lesiones o neoplasias diferentes, sino quizás es una que tiene un espectro de presentación. Hablando específicamente del carcinoma de células de Merkel, ahí yo creo que no cabría la confusión con un carcinoma sebáceo o un carcinoma vasocelular. Ahí con lo que más frecuente se confunde son con lesiones tipo linfomas, y también tendríamos que tener mucho cuidado y, por supuesto, como mostró el doctor Kikawa, marcar con inmunistoquímica para confirmar que estamos tras un carcinoma de glándulas, perdón, carcinoma de células de Merkel.
Claro.
Sí, coincido, una cosita, Ale,
Lourdes, lo que quieras.
Coincido con el doctor Abelardo, que es cierto que muchos tumores, generalmente tanto el sebáceo como el de células escamosas, imbrincan patrones de diferenciación y llevan a la confusión histopatológica con otros tipos de tumores. Lo que es importante acá recalcar, que también sucede con el carcinoma sebáceo, que suelen formar parte de síndromes que acompañan otro tipo de neoplasias a nivel sistémico. Por ejemplo, en el carcinoma de células sebáceas puede ser que sea parte del contexto de un Muir-Torre, y en ese caso se utiliza para marcar, en este caso, inmunistoquímica de tipo inestabilidad microsatelital para este tipo de pacientes. Por supuesto que la inmunistoquímica ayuda para estos casos en los cuales uno tenga que clasificarlo como entidad pura versus una diferenciación. Y para el caso que presentó el doctor Kikawa, a veces preguntarnos si no tiene como base el background el paciente un síndrome genético con alteraciones o mutaciones de la TP53, que son enzimas oncogénicas que disparan directamente la vía oncogenética de ese paciente, y suelen hacer no solamente lesiones cutáneas, sino cutáneas y viscerales. Esos pacientes también es interesante estudiarlo desde el punto de vista de si tienen mutaciones genéticas a nivel de la vía oncogénica, que bueno, para este caso no sé si se habría estudiado o no. Sería una buena pregunta para el doctor si tenía algún síndrome genético determinado previamente.
Dr. Kikawa,
does the patient had Dr. Lourdes Raca wants to know if your patient had any kind of genetic syndrome that you have known of.
Yeah, it's a good question. We queried the patient about that, any history of basal cell nevus syndrome, and she denied anything. So so no, none that we were able to detect. 90 years old, if you live most of your life without too much other health issues, I think probably, they're low likelihood.
Yo tengo una pregunta para Lourdes.
Sí.
Lourdes, perdón, que te entendí, lo que dijiste ahora es que cuando estás en el contexto del estudio histopatológico de un tumor de carcinoma de células sebáceas y uno piensa que están con un síndrome de Muir-Torre, tú le vas a hacer unas tinciones de inmunohistoquímica diferentes.
Se le puede a ese paciente, siempre y cuando cuando piensa en el contexto que suponte el paciente tiene o carcinoma cutáneo o carcinoma mamario, se le puede pedir inestabilidad microsatelital. La inestabilidad microsatelital son enzimas reparadoras, son mismatch repair del DNA, que en este caso estarían mutadas. Entonces, cuando ese paciente en su código genético tiene alguna posibilidad de reparar esa síntesis de DNA que viene errónea, estas enzimas, que son las que capturan esas alteraciones de codificación, están mutadas, no lo pueden hacer. Entonces ese paciente presenta por inmunohistoquímica esa inestabilidad. Se le puede marcar MSH1, MLH1 o 2 a la lesión, sí. También se ha visto como factor que se ha estudiado, que son en otros tumores, en los carcinomas sebáceos, el ER2, que se hace por inmunohistoquímica o por hibridación, por FISH, que es como un factor pronóstico también. Eso se estudió en otros tumores viscerales, como por ejemplo en el carcinoma gástrico, pero también se vio que da positivo en los carcinomas. Se expresa bastante, casi en un 80%. Son técnicas moleculares para poner en evidencia este tipo de pacientes y ver el pronóstico, porque son candidatos a un tipo de droga diferente.
Excelente, muchísimas gracias.
Muy bien.
No, por favor.
Bueno, muchas gracias a todos. Thank you very much, Dr. Kikawa, Dr. Allen, for your participation. Gracias, Rosita, gracias, Simone, y obviamente nosotros los oncocirujanos no seríamos nada sin Abelardo y Lourdes, que son nuestros patólogos, el punto principal de toda la discordancia. Así que bueno, de ser miembro de la Sociedad Argentina de Oncología Oftalmológica, les agradezco a todos, a la gente presente en el YouTube también, las preguntas, y bueno, cerramos este capítulo. Dejo unas palabras al doctor Pelayes o al doctor Chiaradía.
David, you're mute.
Está
David.
muteado, Doc.
You're mute.
Thank you to all the speakers to the great presentation, and was an honor to our society. And I hope also you enjoy the symposium, and thank you a lot. Pablo?
Thank you very much. Awesome presentations. And again, we admire your work, not only for experts in oncology, but also for us, for general ophthalmologists. Thank you very much also for very nice presentations and the pathologists. Thank you very much. Really, we enjoy.
Thank you very much.
Thank you for joining us.
Enjoy, thank you.
Alrighty, thanks.
Have a nice
Thanks,
weekend,
everyone.
Thank you.
Have a nice weekend. Thanks.
Gracias.
Thanks.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Thank you so much.